Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today we're going to talk about clint checks, or it doesn't have to be clint checks, it could be any aligner company, could even be braces, and treating to gum lines versus treating to incisal edge symmetry. And really, I can't answer that question for you. That's a personal choice. Combination of the doctor, who's going to be restoring the case, and the patient, what they want, what they're looking for. I can tell you the vast majority of patients, 99.9%, couldn't give a beep about their incisal, about their gum lines. They usually don't care. It's something that I feel like doctors care about more than patients. So, what I do on every case, and it's just part of an orthodontist brain, is I'm looking at it and thinking, well, first of all, okay, when you're in a computer simulation, there's no way Invisalign or any other aligner company can predict the gingival, how the gums are going to go. Any periodontist can tell you that. I mean, in theory, if you're intruding, the gum may or may not follow the intrusion. In theory, if you are extruding, the gum may or may not follow the extrusion. So you can't predict it. It's a wild card. So I kind of hesitate to treat to it. Don't predict. Just because they say the gum's going to look like this doesn't mean that's the way it's going to go. So I kind of move the tooth the way that I want the tooth to go. Gums can easily be adjusted later with a laser, center of perio, whatever. And if you're doing a restoration, then you treat it to the restoration. That makes sense. I see a lot of doctors that go nuts trying to get the gum lines even, and then it never looks like it did in the clint check, and then they screw up the teeth. So most orthodontists don't. But we ask the restorative dentist, like obviously if I saw a patient like this, which is why I threw this picture in here, like clearly there was trauma on the tooth. So my question, if this patient came into a consult for me as the treating orthodontist, I'm going to ask the patient first, hey, what happened to your tooth? Obviously I'm going to want to look at an x-ray and make sure that tooth is okay. Make sure I don't see any lesions. Make sure I don't see any, exposed pulp or anything like that. And then I'm going to say, what's your plan for this tooth? A lot of times they already have a plan. Yeah, my doctor's planning to put a crown on it after ortho treatment. Okay, that's great, And then I'm going to go to the restorative dentist and say, where do you want me to put this tooth? Do you want me to even out the gum lines? Do you want me to just get extruded as much as possible and you're going to laser the gum line later? Where do you want it? And the restorative dentist is going to tell me where to put it. And then I'm going to double check, show them the clint check, and then we're good to make sure it's good, right? That's how I do it. What else? So anytime I see a clint check, for example, like this one, this gum is a little higher than this one, but obviously we're going to be root correcting this tooth and extruding this a bit, maybe moving the root more this way, which will bring this incisal edge down. So the gum should be pretty even. It's a kid anyways. I'm not going to even think about it. Other thing that you're going to be checking out would be the smile. So I'd want to see the smile line. That makes a huge difference. And if you don't get that big cheesy smile picture in your extraoral photos, then you cannot do a good treatment plan. So that's why it's super important that you have really, really great initial photos, right? Also might look at the Ceph if you got one. That plays definitely a part in it in terms of where we put the incisors. So let's look at this picture, for example. This is another good example. Looking at this case, we see the incisal edges aren't even. So I'm thinking, okay, well, if I extrude this tooth and bring it down, the gum line may also follow it, might not, which will make the gum line lower. Or I could intrude this one, which will make this gum line higher. I'm going to look at the patient's smile line. I'm going to look at the patient's bite to make that decision. Probably at the end, I'm going to get these teeth as close as possible, and then I'm just going to smooth the edges off these teeth. So now I probably wouldn't worry too much about the gum lines, but that's just how I do things. The main thing is to communicate with your patient. And if you have, this is super important, if you have a restoration, any type of restoration, be it incisal composite, a veneer, or a crown that is affecting your ortho outcome, you want to make sure you have that treatment plan locked in. And I always have the patient put down a deposit on that restoration. That way we are locked in. I have my plan. I know how I'm putting the teeth. The patient knows and cannot change their mind because they've already put 50% deposit down on the restoration. I will not treat personally to something funky, like if they're asking me to do this, do that, leave it high, unless I know for sure the patient is locked into that restoration. Because I can tell you as an orthodontist, 98 times out of 100, if I don't do that, the patient changes their mind later and says, you know what? We get to the end. I'm like, you're done. Oh, you know what? Can you just bring this tooth down? I changed my mind. I'm okay if you just bring it down and if the gum lines are uneven. So, and then that takes me another 9 to 12 months, in ortho. And that's frustrating. It's a waste of my time. It's a waste of the patient's time. It's a waste of my money. So I want this treatment plan to be locked in. So that means I'm going to want to get it in writing from the restorative dentist. This is the plan. I'm going to want to get it in writing from the patient. This is the plan. This is how we're treating. Any other changes to this treatment plan will likely have additional fees. Write it down, have them sign it. You don't have to say what the fees are, or you can say what the fees are. Extra 500, extra 1,000, whatever, because this is more time from me. So I really want them to know what their price is and make sure they understand the procedure from their dentist. And if you are doing both the ortho and the restorations together yourself, that makes it a lot easier. You just bundle that whole price up front and give them one big price. Strongly recommended for bridges, implants, anything that's over $100. All right, thanks so much.